Welcome to part 2 of hematology. In this section, we will be discussing some of the benign hematological disorders. Benign doesn't mean they're not dangerous. Benign just means they're not cancerous. Okay, so the first one that we're going to discuss is anemia. So anemia is not really a specific disease, okay? It's more a manifestation of the pathological process, but it is a deficiency in the number of red blood cells, quantity or quality of the hemoglobin, or the volume, so the hematocrit. It could be based on two different things. One is that you don't make enough of the red blood cells. The second is that you're losing them. And you could lose them through actual blood loss, or they could be destroyed. So clinical manifestations, basically what we see in the patient is going to be based on their body's response to tissue hypoxia. If we remember that the red blood cells are meant to carry oxygen, what happens when they don't get oxygen? And there is a difference in how a person presents based on how fast they become anemic. So let's say, for an instance, I have a slow bleed in my GI tract and versus I just cut an artery. We use the hemoglobin levels to determine how severe the anemia is. And we do have it basically to say whether the anemia would be mild, moderate, or severe. And those levels, mild would be a decreased hemoglobin of 10 to 12. Moderate would be a hemoglobin of 6 to 10. And severe, we consider under 6. Most of the time, we will transfuse under 7. So the signs and symptoms that we see will vary based on whether the person has moderate, mild, or severe anemia. So there is a table in your book that I believe it's table 30-3 that really goes over the different signs and symptoms that we may see in a patient based on their level of anemia. So a couple of the things that I do want to take a moment to say is that integumentary, right? So the paler a person gets, the more anemic they may be. Same thing with jaundice, right? Because we get paler if we don't have enough red blood cells, and we have jaundice if we have increased red blood cell destruction. And then cardiopulmonary effects, again, they are basically striated based on the level of anemia that the person has. So while somebody with mild anemia may not have very many signs and symptoms, somebody with severe anemia would have some cardiopulmonary presentations like tachycardia, increased pulse pressure. They may have murmurs. At the same time, with their pulmonary, they may end up, let's say, mild to moderate anemia. They may have dyspnea and exertion. With severe, it may be at rest. So the level of symptoms that you see in the patient experiences will vary based on the level of anemia. Little nod to our older folks. Often we're, I guess, conditioned to think that just because somebody gets older that certain things are normal. Anemia is not considered normal aging. It's more common, but that doesn't make it normal. So just bear that in mind. If you have an older person, for us, one of the main reasons that people have decreased hemoglobins when they're older is some sort of a GI neoplasm. So if you have somebody whose hemoglobin is dropping, one of the first things that you should do is make sure they have the stool for occult blood to make sure they're not bleeding in their GI tract. So the nursing assessment of somebody with anemia, again, we're divided into subjective and objective. So subjective would be some of the main things that we already talked about under regular assessment in hematological system. But we want to know about their past history, medications, once again, dietary. Many of our anemias are related to diet, so things like iron deficiency anemia. We need to know what they look like. So maybe somebody's a vegetarian. Are they getting enough protein? And then objective would be their general appearance, their skin. Are they pale? Are they jaundiced? Respiratory, we want to know basically, are there effects on their cardiopulmonary system based due to the anemia? Neurologic can basically signal to us that what type of anemia we have going on, and then diagnostic findings, which we discussed in the first presentation. The labs that we look at for anemia. So here they are. Oops, let me move this over. So the anemia labs, this is pretty much the down and dirty list for you guys, right? Hemoglobin and hematocrit, very important. Reticulocyte count basically tells us whether or not our body can make the red blood cells. We look at how much hemoglobin concentration there is in the cell. So we want to know, is the cell pale? Does it look robust? Is it like a normal color? Checking their B12 and folate levels helps us identify the cause of anemia. Erythropoietin can tell us if we have a problem with our kidneys or the chemical messenger for the anemia. Total iron binding capacity gives us a measurement of all the proteins that act to bind or transport iron between the tissues and the bone marrow. It's basically an indirect measurement. It is a pretty much general reflection of the amount of transferrin that's present in circulation. But it's not the only thing that can bind, so it can overestimate the transferrin levels. And also, this tends to basically vary with tissue iron stores. So TIBC is higher when iron stores are low and lower when iron stores are high. So transferrin, basically, it's a better indicator of the availability of iron rather than serum iron, because unlike serum iron, the iron that's bound to transferrin is ready to use. Then mean corpuscular volume, MCV, basically tells us the size of the red blood cell, whether they're too big or too small. And then RDW is also another measurement of size. So when we compare if something is a microcytic anemia or a macrocytic anemia, we're basically looking, is the cell smaller than normal or larger than normal? And smaller than normal, you'll see, especially some of our dietary iron deficiency anemias, thalassemia, anemia of chronic disease. And then our macrocytic, basically when something becomes macrocytic, the cell gets larger and larger, waiting for the messenger to divide. And at times it doesn't come, or it comes too late. And that's usually related to folate, B12. Sometimes some antiretroviral drugs do this to a person, chemotherapy. And then some of the other reasons are listed here for you. But again, we look at, is something a microcytic or macrocytic? And your volumes are listed here, your normals. Here are your normal labs, your hemoglobin. So little nuggets here, which is that if you don't have enough hemoglobin, it strains the cardiovascular system. If you have too much hemoglobin, it tends to lead to clotting events, so embolic events. And then your levels, mild, moderate, and severe, which we've discussed already. The hematocrit. We've discussed what it means for hematocrit already. We do not make transfusion decisions basically based on the hematocrit. What we do is we make them based on the hemoglobin. So again, this says 8. In practice, we generally consider it usually less than 7 because blood is in short supply. So it's not one of the things that we just take lightly. So you may have some differences out in the field, but for us, we'll stick with under 8, definitely under 7. But remember, our hematocrit can be changed different ways, right? Whether it could be too big, too much, or too low, right? I'm sorry. Whether it's elevated or decreased. So things that elevate the hematocrit are listed on the left for you. So think about that. If your red blood cells are bigger, then they're going to take up more of a percentage. So that's why elevated hematocrit is there. And then decreased if your red blood cells are small, and some of the other things that cause decreased hematocrit. This is probably one of the most important slides that I think that you can look at to try and understand what's happening with anemias. So the question is, can you make it and can you keep it? Many anemias are one or the other. There are some, if you look at thalassemia, it's on both. So hypoproliferative anemias, you can't make it. So there's a defect in the production of the red blood cells. So the marrow is just not making them. This can be many different reasons. It could be nutrient deficiency, which is listed there. It could be a problem with your kidneys and decreased erythropoietin, a decreased availability of the iron. Then your hemolytic, which is you can't keep it. So that's when your cells are being hemolyzed. Now, it could be coming from something in the body itself, like a thalassemia, sickle cells, that the body destroys those cells, or it could be something mechanical, like a mechanical heart valve. As they start to wear out, especially, they become very hard on the red blood cells and they can chomp them right up. People on dialysis can have hemolytic anemia as well because of the blood going through the tubes, so the trauma. And then we also have blood loss, right? So we have some chronic, so GI bleeding is one of those, cancer. And then acute, that's the one we always think about, that's the 911, something's rupturing, they're bleeding. All right, so the first anemia that we're really going to discuss is going to be iron deficiency anemia. So basically, for iron metabolism to occur, like we need it to make our red blood cells. If we don't get enough dietary iron, then we'll have a defect in the ability to make our hemoglobin. It is the most common nutritional disorder in the world, so you are potentially going to see it. The most susceptible are, of course, the very young women who are in their reproductive years and a poor diet. So the question is, where does the iron go? Blood loss anemia can lead to an iron deficiency anemia, though the most likely you're going to see is going to be nutritionally related. So in general, when we have iron intake, our normal daily intake is enough, but women who are menstruating, pregnant women need more. There could be a problem with malabsorption. So iron absorption actually occurs in the duodenum. So the thing to remember with that is those GI surgeries that affect the duodenum, they can affect your iron absorption. And any diseases or surgery that alter, destroy, or remove that absorptive surface, those can cause anemia. So things like gastrectomy, celiac disease, Crohn's. So blood loss is a major cause of iron deficiency in adults, but chronic blood loss is most commonly, if they were to lose the blood, it would be through the GI or GU. So most times the person doesn't know that they're bleeding, and this sometimes takes time to identify where it came from. Other sources of bleeding would be postmenopausal bleeding, some chronic kidney disease, dialysis. General manifestations, pallor is the most common for iron deficiency anemia. That is going to be a hallmark for you. So go ahead and star and underline that, whatever you want to do. Iron deficiency anemia patients, they're pale. Pale may not always be evident in their skin, right? That is only for light-skinned individuals. You might have to look at the mucous membranes and to see. So you have to take into account the person's normal skin tone and then look for alternatives if the person is darker skin tone. Um, Glossitis would be another manifestation of anemia. It's inflammation of the tongue. And cheilitis, that's angular cheilitis, so that's the little kind of cuts that people get in the corners of their mouths. The laboratory findings are listed here for you. So iron deficiency anemia, the labs we look for are the hemoglobin, hematocrit. We look at all those. We want to know about reticulocytes. We do a stool for OB, so occult blood. Remember, if somebody has a drop in their hemoglobin, we have to consider that that could be a cause. If we don't treat the iron deficiency anemia, severe cases can actually lead to a heart attack, ascites, heart failure, lots of things. So the good news here is that iron deficiency anemia is generally easily treated if it's a dietary issue, right? So we might need to replete the iron. So we do that through nutritional therapy, like so adding iron-rich foods. Question for you. Do you know which foods are iron-rich? We can take oral iron supplements. We can actually do transfusions if the person is ill enough. We can give iron alternate ways as well. We may give it parenteral, so we could give it IV. We may give it IM. So things that we consider when we're deciding what to give is that oral iron is very inexpensive, but it may not be the most appropriate based on the level of anemia that the person is experiencing, right? They may need some immediate replacement and then to be on an iron supplement. Daily dosing for iron is 150 to 200 milligrams. All right, let's look here. So even after we replace those stores, understand that the person still needs to continue on the medication. I want you to take a minute and pause and take a look at all of these different things that we can basically have to know about iron replacement. But some of the little things. So oral iron is best absorbed in an acidic environment. So that's why we want to take it on an empty stomach. So your stomach's more acidic. However, if the patient doesn't tolerate that, then we may have them take it with meals, even though it decreases the absorption, because it's still better to get some than none. Anything that's liquid has the potential to stain teeth. So that's a little NCLEX hit for you. Basically, if they're asking you about a liquid, usually pretty safe to use a straw. There are side effects to oral iron, including constipation, diarrhea, that the stools will become dark. It is not true that they will have a false positive guaiac stool. That's not true, but they will be dark. So the person may need to increase their fluids, their fiber, even take a stool softener. If we are giving parenteral iron, and there's many reasons we might do this, right? Somebody has GI issues, they're just that sick, right? They need iron beyond what normally we can give. We can give it IM or IV. If we give it IM, you must use the Z-Track method for this. This is one of those that it's dark, right? This is a dark, dark medication, and it will stain the skin. And same thing with IV. You want to make sure that your IV is patent before you give this. Okay, we're going to start moving into some of the other anemias. So the first one we're going to talk about is thalassemia. Now, there's two different types of thalassemia. One is considered, it's called thalassemia minor, sometimes called alpha thalassemia. And the second is beta thalassemia major, also called Cooley's anemia, also called beta thalassemia, also called thalassemia major. You'll hear it all different ways. They are basically two arms of the same branch, but couldn't be more different. All right, so thalassemia minor. So when we're talking about these, let me step back and tell you that they're both hereditary, right? Many of these that we're going to talk about, they're hereditary, things like sickle cell, hemophilia, thalassemia. So in order for these to become apparent, you have to have two thalassemic genes. So if you only have one gene from one parent, then you have thalassemia minor, which for the most part is minor, right? Thalassemia major is when you inherit two of those genes, and that is the one that is very life-threatening. So thalassemia is a group of diseases that involve inadequate production of normal hemoglobin. So they can't make it, but then the problem is they also can't keep it, right? So those abnormal hemoglobins are basically destroyed. So decreased production and increased destruction as well. So thalassemia minor is often asymptomatic. The person may have moderate anemia, and if you looked at it under the microscope, that those red blood cells would be small, so they'd be microcytes, and then they'd be hypochromic, so they would be small and pale. But for the most part, because this is the person's normal state of being, the person adapts very well and really no treatments indicated. But thalassemia major, on the other hand, is life-threatening. It is apparent in childhood. The person experiences both physical and mental growth slowing. Jaundice is a very prominent issue here because remember, there's a lot of destruction of red blood cells going on. So jaundice. And when we talk about hemolytic anemias, we want to keep in the back of our mind jaundice, the spleen, the liver, and actually the heart, right? So the spleen gets larger, the liver gets larger, the heart is overworked. It becomes, you can get cardiomyopathy. And if you look here, you have all of this bone growth, right? Basically, the bone marrow is responding to the reduced oxygen carrying capacity of the blood. That stimulates red blood cell production, and the bone marrow becomes packed with these immature red blood cell precursors. And then what happens is those die, and that causes chronic bone marrow hyperplasia. For this, no specific drug or diet is effective. A stem cell transplant would generally be considered curative. However, the risks and dangers of doing it often would outweigh the benefit of that. So most of the time what we do is we do blood transfusions or exchange transfusions with chelating agents. You have to, once again, if we're giving lots of blood, we have to always be worried and mindful about the iron levels. So for these folks, anybody that we're giving a lot of transfusions to, your next question is, what's my iron looking like? Do I need to give a chelating agent as part of their plan of care? We may use other medications that increase urine iron excretion, and a splenectomy may need to be done as well. So those are the takeaways for thalassemia, right? There's the minor and the major. Now there's something called G6PD. It's not a very common one, but for this, I put a bottle of Heinz ketchup because I want you to remember the Heinz bodies. So basically, this is an X-linked recessive mutation where the person's red blood cells, the hemoglobin, everything's normal until something causes them to be stressed. Something stresses the hemoglobin. Now, I don't mean you have a big test coming up, so I'm stressed, so my red blood cells are stressed. No. What I mean is it's usually something dietary, so chemical stressors, medications. So the list is there: sulfonamides, nitrofurantoin, which you may know as macrobid, pyridium, respiricase, and then fava-beans. So basically, if you looked at the peripheral smear, you would see those, looks like little Pac-Mans, right? Basically, the spleen takes a bite out of them, right? Because it takes little Heinz bodies out and bites them. So treatment for this is number one is basically remove the offending medication if that's what it is. I can't stress enough the importance of getting a very good medication reconciliation with these folks, right? Somebody comes in, they have this, they have a new onset hemolytic anemia. Ask them, man. You gotta know what meds are they on. And then we'll now talk about some of the other disorders. We have the megaloblastic anemias. So that says megaloblastic anemias are basically a group of disorders that's characterized by large red blood cells. So this could be a deficiency in a lot of different things like vitamin B12 and folate, somebody may be an alcoholic. But the most common cause of megaloblastic anemia is pernicious anemia. And for that, we'll go right to it, right? Pernicious anemia is basically an absence of intrinsic factor. So when we take in our diet, our B12 cannot just go into the marrow where it needs to. Basically, it needs the intrinsic factor, which is made in the stomach, to bind to that B12 and take it to where it needs to be, right? It can't go without a ride, and that ride is intrinsic factor. This is generally has an insidious onset, so kind of happening in the background, starts in middle age or later. One of the hallmarks for pernicious anemia is the neurological changes, and I put it on the previous slide. It was in yellow, and here it is, paresthesia. So anytime we have neurological changes in a patient, we always want to think about safety. So these are the folks that might have a problem walking. They might have a gait issue, high risk for falls. And because of the lack of intrinsic factor, these folks cannot get oral B12 supplementation. You could have them take an entire bottle, they won't absorb it because they don't have the intrinsic factor. So this is why they need some sort of parenteral form, usually IM, every month for life. If somebody had pernicious anemia and it wasn't treated, they would be dead in a matter of a couple of years. So some things we need to talk to them about is basically that even though they'll start to recover their stores, they're going to need to, their neurological signs and symptoms may take longer to go away. And I think that's about it. So it needs to be for life, needs to be IM. All right, so let's talk about some of our sort of chronic anemias. So renal disease can cause a decrease in erythropoietin. This is why it's very common that you will see patients in dialysis on Aranesp or darbepoetin alpha, some sort of growth factor. For these, the cells are small, and then of course dialysis, we can lose some there. And then anemia of chronic disease. Basically, if somebody's got anemia because of some other chronic condition, the treatment really is to treat the underlying disorder. They do not benefit from their iron supplements or anything else because that's not their problem. It's usually a milder anemia noticed over several weeks. It's not something that's just super acute. And if you looked at the peripheral smear, those cells would be low number, but they'd be normal size and normal color. If you were to run labs on somebody who had like an anemia of chronic disease, you would find generally an increased serum ferritin, increased irons, but a normal folate. And again, treating the underlying cause is best. We may use blood transfusions for severe cases, and there's a limited role for erythropoietin. Very, very limited. The next thing we're going to talk about now is aplastic anemia. I consider this to be bone marrow failure, right? So aplastic anemia, it's pancytopenia, which means there's a decrease in all blood cell types. And you can see my little picture I have here, like the normal look, and then basically aplastic anemia cells. Everything is decreased. This can be from a very mild thing to very severe and life-threatening. It can be abrupt or it can be insidious. The signs and symptoms that you see would be those that are relating to a decreased number of white cells, red cells, and platelets. So it could be a suppression by one or all of those elements. So what might you see? Somebody's bleeding. They're severely anemic. They have a recurrent infection. There are some general manifestations of anemia. The person may have fatigue, dyspnea, some cardiovascular, cerebral responses, neutropenia, thrombocytopenia as well. So diagnosis is confirmed with the lab studies, and we would see a decreased hemoglobin, decreased white blood cell, decreased platelets, decreased reticulocyte, because remember our reticulocytes are those immature red blood cells, so we're not making them. And then if you looked at the bone marrow, it would be hypocellular. So the treatment really is to identify and remove the causative agent when possible. There are certain medications that are implicated in this. So I want you to use your detective work and think of a couple. We would then try some immunosuppressive therapy. So we might use anti-thymocyte globulin, steroids, cyclophosphamide, cyclosporin. If that doesn't work, we may have to do a stem cell transplant. And there's a couple caveats to that. It means if they're not responding to immunotherapy and they're under age 55. Might you see it that somebody's over the age of 55 and gets a stem cell transplant? Sure, but that's not textbook care. Nursing needs to step in and provide that supportive care until that pancytopenia resolves. So just like we talked about under cancer, here it is again. And what does that look like? Infection, hemorrhage, and severe anemia. And remember, if we're giving them transfusions, they may need iron chelation. Okay, the next anemia we're going to talk about is sickle cell disease. It is inherited. It is autosomal. Basically, we get an abnormal form of hemoglobin. That's that hemoglobin S. It is incurable, so there's no cure, and it does affect the quality and the quantity of life. All right, so people do not tend to live as long when they have sickle cell disease. So let's look at what happens in this. Basically, there's a substitution in our hemoglobin chain, which causes the red blood cell to stiffen and elongate. And that occurs when there's decreased oxygen levels, so they sickle. And what we see are the side effects or the effects of that sickling. Sickled cells are stiff, they're angular, they cause clotting, they get stuck in small capillaries, and they can cause a sickle cell crisis and sequestration of basically organs. Now, there's a few different types of sickle cell disease. There's sickle cell anemia. That's the one that we're going to talk about, the most severe. They have a sickle cell thalassemia, sickle cell hemoglobin C, and then the trait. So again, the one when we talk about sickle cell, we're actually talking about sickle cell anemia. So here's how it's passed down. Basically, if parents are both carriers, they have a 1 in 4 chance that their child has it. Half of the time, the child will be a carrier, and 0.25% the time, the child would be unaffected, not a carrier, whatever. So we concern ourselves with basically diagnosing, excuse me for tripping over my words today, but diagnosing sickle cell anemia. And we do screening at birth to pick this up. We know that it's more common in African American, Middle Eastern, and Mediterranean populations. Very common among African Americans to express the trait. The trait does not mean they have the disease. It's not as benign as people make it out to be, like, oh, there's no problems, but it's nowhere near a sickle cell anemia. And what we're trying to do when we have patients with sickle cell anemia is to keep them from going into crisis. So a sickle cell crisis basically can become life-threatening. It can cause shock as a result of the oxygen depletion and the tissues and decreased circulating fluid. So there's a couple things. So we have the acute chest syndrome. Basically, this looks like a pneumonia, acts like a pneumonia. Basically, ends up with an increased risk of infection, usually pneumococcal pneumonia. We have the acute vaso-occlusive crisis. That is the one we think about with sickle cell crisis. Person experiences basically pain from tissue hypoxia and damage, pallor, jaundice, gallstones. Infection is a major cause of morbidity and mortality. So we'll talk about that more in a minute. And the sequestration crisis. So that's basically the organs get attacked. So the autosplenectomy. So basically, by the time a person is 10 years old that has sickle cell, often their spleen has already been destroyed. All right, so some of the clinical manifestations you can see here. I like this. Basically shows you that sickle cell affects every area of the body. Lungs, including pneumonia. And again, lung complications, pneumonia, tissue infractions, fat embolisms. Many serious complications. The splenic atrophy can lead to heart failure. Jaundice. Jaundice is a very common finding among patients with sickle cell disease. Priapism can be a sign, and then skin. Very common for people with sickle cell disease to have stasis ulcers, and they would be mostly hands, ankles, and feet. All right, so treatment of sickle cell really falls on a couple things. One is prevention. All right, the best thing we can do for somebody with sickle cell disease is to keep them from going into crisis, because crisis can become deadly. So for that, it's a whole bunch of patient teaching. These are the folks, they need to have their vaccines. They cannot expose themselves to extreme heat and cold. They should not go into thinned oxygen areas, so they need to make sure that they're not at too high of an altitude. Avoiding crowds. I think I mentioned vaccines. I'll mention it again. Vaccines are super important. Pneumococcal and influenza. Once somebody is in crisis or looks to be going into crisis, I put the HOP up here. You really have to hop to treatment, right? So hydration. One of my golden rules, if you have too much of something, you need to thin it out. So we have too many sickled cells and they're close together, so let's thin them out. Fluids, we can expect fluid boluses. Oxygen, because of the hypoxia at the tissue level. And then pain. Please remember that a person can get pain medication tolerance. And during a sickle cell crisis, they will require continuous and breakthrough pain medication, including things like morphine and Dilaudid. If they do complain of pain, at that time it's usually in their back, their hips, their upper extremities, lower extremities. Folic acid is an important part of the care of a person with sickle cell disease. hydria. Hydroxyurea is the other name for that. So hydroxyurea is one medication that is shown to truly be clinically beneficial. What it does is it increases hemoglobin F. So that is the fetal hemoglobin. It causes an increase in that, and that's more of a normal type of hemoglobin, better than the hemoglobin S. So again, the patient teaching, very important on how to avoid the crises, maintaining adequate fluid intake, getting their vaccines, their immunizations, prompt medical attention at the first sign of infection or other signs of crisis, and pain control. And then we'll look at the next slide. You can see here that this person is getting a transfusion, but she's also giving blood. This is an exchange transfusion. When we do this, the goal is to keep that hemoglobin S level less than 30% and decrease how thick the blood is. If we do a transfusion, the target there is generally to keep that hemoglobin around 10. We don't want so many red blood cells rolling around in the bloodstream, because what happens in the event that they become hypoxic, you'll have more to sickle. Remember what I said with the transfusions. Anytime we're giving multiple transfusions, we need to be concerned about iron overload. And then there's something called alloimmunization. So basically, the more transfusions a person gets, the more likely they are to develop antibodies. This makes it harder and harder to type and cross these folks for different transfusions. So if they need blood, they may not get it right away. Okay, the next thing we're going to talk about is acquired hemolytic anemia. Just a little nod to this, but basically our red blood cells get hemolyzed from extrinsic factors. So things like physically being destroyed. We talked about mechanical heart valves. They could have malaria. Some of the autoimmune disorders like lupus, some medications can cause it. So just want to put that out there. Infection can actually cause hemolysis 3 different ways, right? It can invade the red blood cell. It can release hemolytic substances. Things like C. diff do that. And then also cause antibody reactions. But you have to know all that. That's kind of nice to know. Next thing we'll talk about, and again, if you guys get tired or whatever, you can pause this at any time and come back to it. Hemochromatosis. So basically, this is another one of those disorders that is inherited. It's autosomal recessive. Basically, it results in iron accumulation in the tissues and the organs. This one affects those of European ancestry. Pretty variable expression clinically, but you can see the different things that may happen out there, like basically cirrhosis, bronze skin, diabetes, hypogonadism, joint pain. So a lot of things can happen there. So the treatment for this one, hemochromatosis, if we have too much iron, we have to get rid of the iron. So how do we get rid of it? Well, it's in the blood, so we can do blood removal. So removing 500 mLs of blood every week for 2 to 3 years, and then also iron chelating agents. So deferoxamine would be your exemplar medication. So this is bleeding, basically. So that's too much iron. Now let's talk about some of the other issues that we could have with too much of something. So too many red blood cells. Now there's a difference here between polycythemia, primary polycythemia, which is called polycythemia vera, and secondary. So secondary polycythemia is your body's adaptation response. Basically, there's not enough oxygen on board, so the body responds. These could be due to things like oxygen doping, smoking, lung disease, living in a high altitude. So basically, that's not a cancerous issue. What is polycythemia vera. And the hallmarks for that would be splenomegaly and hepatomegaly. It hits the older folks. And anytime we see this, like polycythemia, we want to consider these people potential clotters, right? So you can pause on here and kind of look at what I have for you to see. But what do we see? Previous slide said median age is 60. This says 65. Just must have been different sources. But basically, these people, I think of them as like Santa Clauses. Older, white male. So who's an older white guy? Santa. And that ruddy complexion, but they could also have headaches, dizziness, some of the central nervous system issues. Because their blood is too thick, hypertension, claudication. The uric acid level tends to be elevated. And the treatment for here is to, again, they're potential clotters, so we often give these guys aspirin, and we do phlebotomy or bloodletting to keep their hematocrit on the lower end. We're going to go into some of the platelet disorders, and we'll just pause here to once again look at thrombocytopenia. So one of the important ones is what we call ITP, so immune or idiopathic thrombocytopenic purpura. For this, we end up developing some antiplatelet antibodies, which causes the platelets to be destroyed in the spleen, liver, and even in the lymph nodes. More common in children and young women, so that's why I have a picture of a little kid there. It could be primary or secondary. Primary means it's the disease itself. Secondary means something else causes it. But let's talk about the meat and potatoes here, right? It's how do we treat it? What's going on here? So these guys are potential bleeders, right? And we already talked about what that means if our platelets fall. So platelets under 20, then we need to usually replace those platelets. Treatment, we start with immunosuppressive agents. So prednisone would be the first line. They might try some IVIG. And if that doesn't work, one of the things we do would be splenectomy. So we talked about the spleen and splenectomy. By taking that spleen out, it returns the platelets to circulation so they can't hide in the spleen anymore, which decreases the risk of bleeding for these patients. So care and treatment. Basically, here it is for you, right? If somebody's at risk for bleeding, bleeding is bleeding is bleeding. Many of these things can go towards pretty much all thrombocytopenias. Hold the sulfameds, no aspirin, no NSAIDs. We're going to be checking for signs of bleeding, right? People might bleed in their brain, might have signs of like the worst headache of their life. Avoid invasive procedures. Avoid doing those things which can cause bleeding. So bearing down can cause GI bleeding. And then this one does have a little bit of some of the calcium, vitamin D, and biphosphonates because it does affect the bone marrow a bit more. So just to note that, nothing earth-shattering. We'll segue into heparin for a moment here. Heparin is one of the most common medications you're going to be giving. We can give it sub-Q prophylactically for a DVT prevention. If somebody has potential thrombosis somewhere, whether it's arterial, venous, or clot in the coronary circulation, they may go on IV heparin. And we do monitor that by the PTT and then the anti-heparin factor 10A. So that's the activated factor 10. So these guys, I can't stress it enough. It's important to know your labs. Heparin is monitored by PTT or anti-XA. So think about some of the other meds. Warfarin, what is that monitored by? It should say PTI&R, right? So there's a problem with heparin. Sometimes people, when we give it to them, they can have an allergic reaction. And this is why this belongs here under this section. because it's a cause for decreased platelets. So basically, the person has a reaction to the heparin and they inactivate the heparin. That causes increased embolic events. So that's why we say VTE, that's venous thromboembolism, becomes a major clinical concern. For this, we monitor people who go on heparin to make sure that their platelets aren't falling. We're looking for them to be under 150,000 or 50% from their baseline. So this means somebody could have a normal platelet count and still have heparin-induced thrombocytopenia syndrome. And this generally occurs 5 to 10 days after they start the heparin. Any heparin can do this, but it's less likely with Lovenox. So what do? Somebody has heparin-induced thrombocytopenia, then we need to stop all heparin. They should not take this ever again. If they have severe clotting, we can try and get them out with plasmapheresis. The antidote is protamine sulfate. And then, of course, it's the treatment of the sequela for what would happen if there were clots. And then these folks would be appropriate to go on a direct thrombin inhibitor, or they could also go Coumadin, but only once their platelets are back within normal range. All right, we'll spend just a minute to talk about hemophilia and von Willebrand disease. That'd be our next 3 slides. So hemophilia is X-linked. It's recessive, which means that it basically is passed down from the mother, and the male children are more affected by it because they only get the X from the mom. They get a Y from the dad, so it's X-linked. Females can be asymptomatic carriers. Tends to run in some royal families. So we've all heard the stories of Tsar Nicholas and the royal family. They have a lot of hemophiliacs. There can be a couple different ones. 2 that we look at are hemophilia A and hemophilia B. So hemophilia A is factor 8 deficiency, and hemophilia B is factor 9, which is also called Christmas disease. Hemophilia can range from the very mild to not knowing they truly have it until they get some sort of injury later in life to the severe, absolutely severe. And this is basically the signs and symptoms would be a slow, persistent, prolonged bleeding, which can become life-threatening, and even bleeding spontaneously or even after minor injuries. Hemarthrosis would be a concern here that is basically bleeding in the joint, which is a major cause of disability as these folks grow up. And of course, peripheral nerve compression compartment syndrome with the swelling. So let's take a look at this little guy here on the next slide. You can see that this is a child, and you can see the massive hematoma that he has there. So how do we treat this, right? That's the main thing, is how do we treat hemophilia? Used to be there was no treatment, and children would pass away if they had the severe disease. They can live a lot longer now. We have found out that we can give them factor replacement. So the main thing is if somebody is missing a factor, replace it. Guys, that's like your priority. I call these people colanders. Basically, they're missing the factor. So if they're bleeding, you can dump as much blood in them as you want. They're going to continue to bleed out that blood. You have to plug the holes, right? So just think about a colander with water running through it. Well, now, instead of a colander, let's close those holes up and have a bowl. You get to keep what we give you then. Desmopressin is a treatment it can increase factor 8 and also von Willebrand factor. So desmopressin, DDAVP, has a role in von Willebrand as well. Any injury with these people requires prompt evaluation. They may need to have prolonged treatment to maintain hemostasis, longer than you would ever think, right? So even like a couple days of pretty much direct pressure after a minor injury. So here's von Willebrand. So this one is the most common inherited bleeding disorder, affects males and females. And so you'll see this sometimes in ladies, what we'll see, prolonged bleeding, with their menses. Their labs will that they'll have a normal platelet count, normal PTINR, and a normal APTT. That's a little bit different because our other diseases, they had a prolonged APTT, so arthro activated prothrombin time. Treatment here is desmopressin. That's a first line. If that doesn't work, they do have a von Willebrand factor, which is actually second line. So if you see these, I just want you to understand von Willebrand, they're bleeders, right? You have to treat them as potential bleeders. All right, so the next ones that we're going to discuss are going to be hypercoagulable disorders of the platelets. So basically, thrombophilia is love of clots. There's many different reasons this may occur. Factor V Leiden, it could be a protein C or S deficiency, malignancies, atherosclerotic vessels, you name it, can cause clotting. So remember, we want to treat these guys all as potential clotters. So how do we prevent blood clots? Well, we avoid circulatory stasis, right? So we don't want people sitting for long times. So we don't want people crossing their legs. We use the anti-embolism stockings. Medications here, you have aspirin, clopidogrel, Xarelto or rivaroxaban, and warfarin. And of course, avoiding tobacco and nicotine, as that is a vasoconstrictor. Okay, the last section we're going to talk about in this area is going to be DIC, or disseminated intravascular coagulation. So this right here is the patho behind DIC. Basically, something triggers clotting, which causes consumption of the platelets and our clotting factors, which leads to like all these little microclots and depletion of our other factors, which causes them to bleed. So that the trigger can be, you can see it all listed here: injuries, surgeries, burns, cancers, infections, shock. By far and away, the most common that we see this in would be sepsis, so infections. So what do we do, right? What do we see? What do we do? So these people are clotting and bleeding at the same time. What we see in the field, what we're going to see on the patient, is petechiae, yet they'll be bleeding. So bleeding in all the organs. How might NCLEX tell you somebody's bleeding? They'll say bleeding from a venipuncture site, bloody nose, GI bleeding with abdominal cramps. They're going to make it clear that the person is bleeding. So how do we diagnose it? The D-dimer, that lab we read about and have talked about a couple times already. And then you would see their labs would also have decreased platelets, decreased fibrinogen, but prolonged clotting times. So those are the labs that you're specifically looking for. So DIC never comes on its own. It always comes because of something else. And we know that the number one is sepsis. So you have to treat whatever underlying disease or condition is going on. Otherwise, it's pretty much supportive care until we can do that. This includes controlling ongoing thrombosis and bleeding. So if the patient's bleeding, then we give them blood products while treating the underlying cause. There is something called chronic DIC. That means we're not technically using up all of the clotting factors, though, so they're not like deathly ill, but they can become at any time. So we need to monitor those people. So as long as they're not bleeding. So remember, DIC, they're bleeding and clotting at the same time. The main thing that's going to kill somebody would be bleeding. So that's what we go after. All right, guys, this has been an hour long. You can say hopefully broken into pieces and can go back and listen to your favorite parts. I'll see you.